I'm very glad to present Robert van Vorstenbosch from the Maastricht University. Robert is currently undertaking his PhD position at Maastricht University in the Department of Pharmacology and Toxicology under the supervision of our dear friend Aggie Smolensky and Frederic Jean Verschutten. He's studying the possibilities of detecting colorectal cancer using exhaled breath and fecal profiles. He studied chemistry and forensic science, and his passion is to combine advanced machine learning techniques with novel analytical omics methodologies to aid healthcare development. And in his talk today, Robert will present the detection of colorectal cancer via exhaled breath analysis, where we stand and where we go. Robert.
Welcome everyone at my presentation that I entitled The Detection of Colorectal Cancer in Exhaled Breath. And today we'll talk about where we stand now and where we go from here onwards. My name is Robert van Vorstenbosch and I am a PhD candidate at Maastricht University under the supervision of Aggie Smolenska and Frederic Jan Verschutten. Every year, almost 500,000 people are diagnosed with colorectal cancer within the European Union alone, which adds up to 4 times the entire city of Maastricht. Similarly, and unfortunately, every year there are about 250,000 casualties. Of all of these cases, 10 to 20% of them develop via so-called serrated neoplasia pathway. The majority, however, 70 to 90% of all cases develop via so-called adenoma-carcinoma sequence. And this basically means that healthy individuals develop so-called non-advanced adenomas, which in turn develop into advanced adenomas, and these can become cancerous. Now, that entire process takes quite long, which basically gives us the opportunity to try to detect the disease at an early stage. Now, why is this important? As you probably already know, patients diagnosed with stage 1 colorectal cancer have a 90% survival rate. However, patients diagnosed with stage 4 colorectal cancer have a 14% survival rate. In other words, if you want to do something about the number of casualties related to colorectal cancer, we need to detect the disease at an early stage. In the Netherlands, we try to do that by making use of a screening procedure for the general population, which consists of a fecal immunochemical test in which you basically test stool samples for the presence of blood, and when tested positive, a follow-up colonoscopy. Now, there are some problems related to this fecal immunochemical test, also the FIT. First of all, the sensitivity is pretty low. So the sensitivity of FIT to detect colorectal cancer is roughly 73%. The sensitivity of FIT to detect the clinically relevant advanced adenoma cases is 25%. So of all those people who need help, we are only finding 1 out of 4 cases. Now, there are even a couple of more problems. So if you look at your FIT positive population, you will find that about 7% of that population will show to have colorectal cancer. About 40% of that population will show to have these clinically relevant advanced adenoma cases, but all the others will not really be clinically relevant, meaning the false positive rate of the FIT is almost 50%, meaning a real increase on the burden of endoscopic facilities while missing out a lot of relevant cases. Now, honestly, the FIT is super valuable, it's very helpful, but based on these numbers, we can conclude it's suboptimal. So what we hope is that breath testing can be applied to create a more optimal overall screening procedure. That's what I will be talking about today. I will start off with a clinical pilot study related to breath testing and CRC screening. During this study, we were challenged with some data analytical problems, and I will explain to you how we dealt with them. And I will end up with by telling you what we envision for future research. Part of that should include fecal sampling. We made a fecal sampling methodology, which I will also talk about. So let's start with this clinical pilot study. Just very small comments beforehand. The prevalence of colorectal cancer and advanced adenomas in the general population is pretty low, 0.4 and 4.6%. So what we did in our study is we only included FIT positives, which let's say enabled a better or more informative or better balanced sample cohort. So how does this work? In the Netherlands, every year, a general population between 55 and 75 years old can take part in this screening procedure. The first step is to do a FIT. When tested positive, these individuals are invited for a pre-screening intake, in which people explain to them how the bowel cleansing works, how the colonoscopy works, etc. And it is at this point in time that we perform the breath sampling. The breath sampling was performed using 3-liter Tepler bags, after which the contents were chemically analyzed using TD-GCMS. And the patients were subdivided into 1 out of 4 patient groups based on the most advanced lesions found. In the end, this resulted in 30 colorectal cancer cases, 138 advanced adenoma cases, 130 non-advanced adenoma cases, and 84 negative controls. The next step was to compare profiles of each patient's groups for predictive modeling, and it will start with the comparison of advanced adenomas versus negative controls. Here I provide you a very brief overview of the data analytical steps that were undertaken. The first step was to pre-process the raw GCMS data, and after that this data was transformed and corrected for technical variations over time, also batch effects. After that, the data set was split up into a training set and an independent test set. This training set was used to build and optimize a random forest model in which the number and the exact features to be included were optimized. We then obtained our final random forest model. Using internal validation, the predictions of the training set were obtained, but also this model was tested using the independent test set. On this slide, I'm showing you the results that we obtained. On the left, the principal coordinate analysis of the proximities of all the samples according to this final random forest model. Here we see quite a nice separation between, in blue, the control samples, and in red, the advanced adenoma samples. In the middle, we see the RC curve of our training set, where we obtained a sensitivity and specificity of 79 and 70% respectively. Then on the right, I show you the RC curve of the independent test set. And what I would like you to see is that its shape is pretty similar to the RC curve of the training set. They were verifying the results. The next step was to identify those compounds that were found to be most important according to this model. I do have to note that these are putative identifications, but what I hope you see is that quite a few of these compounds do seem to relate to the microenvironment of the colon, so that seems very promising. Now then the next step, or perhaps even the main question, was to compare colorectal cancer cases versus negative controls. But there was one big problem, and that is that we only had 30 colorectal cancer cases, which is really not a lot, especially in these type of very complex data sets. what you would normally do is then maybe still try to create a predictive discriminatory model. But anyone working in this field will say that you are probably going to create an overfitted, very statistically biased model with in the end no biological meaning at all. In other words, you would not be able to use that model in practice. Now, there are a few, let's say, data analytical approaches to deal with such type of class imbalanced data sets. These approaches include resampling strategies or perhaps strategies including synthetic data sets. However, what we used in our study was also the one that turned out to be the best one. For us was one-class classification, and then more precisely the isolation forest procedure. A few words on one-class classification. So in contrast to, let's say, more traditional, for example, random forest models that consider difference, one-class classification considers similarity. And as a result, no assumptions on feature importance are made, meaning no potentially biased feature selection is even needed. And also no assumptions on distributions of features, and perhaps most importantly and quite obviously, these models are not influenced by class imbalance because they are only based on one class at a time. Again, a few words on the data analytical approach. Again, the data was pre-processed, and what we did in our one-class modeling is that we built a one-class model based on only the colorectal cancer cases. Using internal validation, we obtained the probabilities of every single colorectal cancer sample belonging to that group. We used the negative controls as a test set, so we also calculated probabilities of these samples belonging to the colorectal cancer group. And then in the end, we have the probabilities of every single sample belonging to the colorectal cancer group. Then we do the same thing for the other group. So as a final result, we have the probabilities of every single sample belonging to either one of both groups. Now here you see the result of that analysis, where I show you on the right ROC curve, where you obtain the sensitivity and specificity of 67.3 and 70%. Perhaps these results are not as impressive as you hoped, but just remember that we value this approach for being least statistically biased, and also introducing no potentially biased feature selection because we only had 30 cases. A very brief conclusion. So we think the feasibility of using breath testing for colorectal cancer screening is hereby shown, although obviously further research is needed. And what we think is that you can use breath testing to either reduce burden at endoscopic facilities by implementing FIT as well as breath testing, or you can try to improve the overall primary screening by also considering these very clinically relevant advanced adenoma cases. So the next step for us was to think, okay, what should further research focus on? And what we think would be very interesting and valuable would be to include fecal analysis. Fecal samples contain a lot of gut metabolites, and these gut metabolites are considered a functional readout of the gut microbiome, and this microbiome has shown to be very relevant in colorectal cancer development. So we've been busy with two separate sampling strategies using either the microchamber and the high sorb, both of which with pro and cons are shown on this slide. And for now, I will tell you a few things about the microchamber, for which we optimized the entire sampling strategy. Now, I will not bore you with that entire procedure, but what is maybe interesting to share is that during the optimization of the microchamber, I included 5 volunteers. One of these volunteers was lactose intolerant and really clustered very differently with all of the other volunteers. Interesting to add is that this volunteer here in blue had exactly that same diet as the volunteer here shown in red. I don't want to overanalyze or overinterpret these results, but I do think it hints at the promise of these analyses. Now, what kind of compounds do we see? We see a lot of short-chain fatty acids, branched short-chain fatty acids, sulfides, phenol, etc. So all of these, let's say, very interesting volatiles that if you want to do research into any colon disease are very interesting. And per person, we found 200 to 300 compounds. Then very shortly, what are we going to do upcoming year? Upcoming year, we want to basically start sampling for a new study cohort with at least 600 fit positives. Additionally, we want to include 150 inflammatory bowel disease patients, as well as 150 irritable bowel syndrome patients. We want to sort of update our sampling and analysis strategies. This will mean that we will include fecal sample, and the breath sampling will be updated from Tetler bags to the Receiva system. Samples from every patient will be analyzed using GC-TOF-MS, GC-GC-MS, and GC high-resolution MS. And this will be enabled because this will be a multi-center setup between Maastricht University, the Fraunhofer Institute, and Boston Medical. So, as our overall conclusion, the pilot study seems very promising, although more research is needed, and we will do this upcoming year using the Receiva device, the fecal sampling, etc., the stuff that I just told you about. That was my presentation. Thank you very much for your attention. I would like to acknowledge the team on this slide, especially Aggie Smolinska and Frederik Jan van Schoten. And I would be very happy to receive any questions now.
Thank you very much, Robert. Very exciting presentation. And as you said, very promising results. Before we move to the question chat, one that I've been thinking about, you described exhaled breath and you described feces. Both are very rich metrics for volatile organic compounds. To which extent do you think those both metrics will be have in common or differences? Do you think that you mentioned the focus on the microbiome, gut microbiome, and feces? How do you think that would be different or give you probably different clinical performance compared to breath?
Well, I'm not sure if I understand your question correctly, but I think, well, first of all, fecal samples will add a lot of information that will try for us to help understand, let's say, the overall biological system of colorectal cancer, which, for example, diet, the microbiome, let's say host metabolome, in which that all plays a role. So it has to do with trying to understand the disease, trying to understand where these biomarkers are coming from. But on the other hand, also perhaps trying to create better diagnosis tests. And when you compare, perhaps from an analytical point of view, the fecal sampling to the exhaled breath analysis, the exhaled breath analysis can be very much challenged by, let's say, the amount of background VOCs that we see. When we compare that for the fecal analysis, we see that the machine blanks, let's say, are very clean, almost totally, well, blank, let's say. And we catch a very clear signal to fecal sampling. So that is, from an analytical point of view, very different from the exhaled breath analysis as well.
Thank you very much. We have a few questions here in the chat. One question here from Manohar. Did you try other data analysis approaches other than the isolation forest method?
Yeah, we did try other approaches as well. In the end, the isolation forest approach was, let's say, the preferred one because it doesn't assume any data distributions, no normality constraints, etc. So with that, it can also deal with sparse data. And if you compare that to other data analytical approaches, there are often more assumptions made in these. So that's why we in the end chose for the isolation forest.
And on that note, have you tried any type of a series of univariate analysis, for example, such as tree of decision, for example, based on univariate after univariate, instead of combination, I mean?
No, we haven't tried that approach. No. No.
Okay, and here's a question from Andrea. Andrea is asking how many of those VOCs were identified? I remember in, I think, one of your slides you showed still with unknowns. Are you working on identification, elucidation of those compounds?
Yeah. So how we normally take a very untargeted approach, which is perhaps for a lot of people not a favorite way. I know that you have been working on the Omni assay in which you really try to define a very large targeted set of compounds really well. I can't say we have that really yet for the fecal sampling. So this is also a bit based on a, let's say, untargeted approach while removing a lot of let's say noisy features. So, but not all of them have been identified.
Okay, I think we have time for one more question. Here's a question from Mark. Even with limited number of samples, why can't multivariate analysis be undertaken if care is taken in feature selection, statistical power, given the effect size, cross-validation and independent validation?
A very good question. First of all, we felt very strongly that with only 30 colorectal cancer cases, we really did not have a lot of room for any validation. That was a very big problem. So we have our, let's say, our very complex data matrix, which you want to look for very complex patterns. But with only 30 samples, there's really not a lot of space to even have like an internal validation scheme, yet alone an independent internal validation. So that was one of the major challenges. And what we were very afraid of, if we would choose that approach, is that our biomarker selection would be very biased. So of course you can make a discriminatory model, but it doesn't mean that it will be meaningful in the end.
Okay, and last question here, short one from Scott. Scott is asking regarding the data pre-processing that you have used.
Yeah, a combination of wavelets, p-splines, probabilistic quotient normalization, combat for the removal of batch effects. Yeah, overall quite a lot, I have to say. Scott, if you wish, and I can perhaps send you some more details about that via email or via the chat.
Okay, thank you very much, Robert, and good luck in the future study. Thank you for sharing your research and initial results with us.
Thank you very much, and thank you for giving me the opportunity to present here.
It's always our pleasure.